Coming to you live from Charleston, South Carolina, Champion Studio in Charleston, South Carolina, on an amazing Friday afternoon. It is Better Than Ever Live, wherever you're watching. I hope you make today, this weekend, and every day, I hope you make it your masterpiece. My name is Dr. David Geier, orthopedic surgeon, sports medicine specialist, and media medical expert. I help you feel and perform your best, regardless of age, injuries, or any medical conditions you might have. Really excited to be here. Doing a little different. We're not doing a bunch of studies and research on nutrition and aging and sleep and longevity, all this kind of stuff for overall health and feeling and performing your best. I'm going to answer some of your questions. If they're health questions, if they're wellness questions, exercise, nutrition, sleep, that's all great. Or if they're getting back to my background, orthopedic type questions, sports medicine questions, bone, joint, muscle, tendon, ligament, I am here to answer that as well. Remember, this is not specific medical advice. Any answers, any information that I give, obviously, this is meant for general information and educational purposes only. I am not giving you advice, answering your question, telling you what to do. If you have specific questions, you need to talk to your doctor. But I would like to give information in a way, hopefully, that maybe can clarify something that you know or something like that. All right, I do want to say that I am in a really good mood today because my Memphis Grizzlies are doing great this year. I don't remember, those of you that have watched the Better Than Ever Live since it started, you've probably heard me mention a couple times that my hometown is Memphis, Tennessee. I obviously live in Charleston, South Carolina now, but I still call Memphis my hometown. Huge Memphis Grizzlies fan. They had a huge win last night beating the Golden State Warriors, who quite honestly I don't particularly care for, despite the fact that my brother and my nephew are enormous Golden State fans. My brother went to Davidson, and I think to graduate from Davidson you have to sign a contract legally obligating you to be a Steph Curry fan or something like that. I don't know. I was thrilled that we beat them in overtime. I got this is going up in Champion Studio, more paraphernalia, my Believe Memphis playoff towel, my Memphis, if you can see that, Memphis versus Buddy paraphernalia. And, those of you that remember back in the days of, I guess about 3 years ago, I did Ask Dr. Geier live videos on Wednesday nights. And the studio was set up a little differently. I didn't have all the TV studio lights and everything and cameras and all, and it was closer to the wall. And so people could see my Liverpool paraphernalia. I'm a huge Liverpool fan, English Premier League soccer. I've been a Liverpool fan since probably 2000 or so. And that was very polarizing on those Ask Dr. Geier lives. I'd get the people that were big Liverpool fans that would always type YNWA. For those of Liverpool fans, they know that means You'll Never Walk Alone. That's the anthem that Liverpool sings at the beginning of the fans sing at the beginning of the game at Anfield and at the end of the game. And then I'd get the usually Manchester United fans, but people that hate Liverpool that would leave nasty comments, and then I wouldn't answer their questions, and maybe I'll do that here too. But really excited. Memphis playing well. Liverpool destroying United on Sunday, 5-0 at Old Trafford. Very good. So ask away any questions you have. I have a couple that I got ahead of time. I'm realizing very quickly one of the challenges with this is going to be to stream this out to YouTube and Facebook and LinkedIn at the same time. I don't go natively into any of those platforms. I use a service called Restream, and I realized that now I can't see comments that were left in the preview post, at least on YouTube that I saw, so I have no way of getting to those. So if you left a comment in the chat or comments beforehand, which may or may not even be there anymore because they're not showing up in Restream, I apologize. Please submit those again. But I do have a couple that I did. I remember what the topic was, so I will get to that. Robert, I very much appreciate, seems to be here most of my live shows at 12 p.m. Eastern. I really appreciate it, Robert Simpson. And let me know at some point, Robert, where you are. Is it necessary to take vitamin K2 with vitamin D3? All right, so that's really interesting in that if you had asked most people up to about a year ago, maybe 18 months ago, they say, no, you just need vitamin D. And vitamin D is important. I'm not going to say that. That definitely is. And if you happen to live, especially in the South or somewhere, and you're outdoors a lot, you probably don't even need vitamin D supplementation. You get it enough through the sunlight. But up in the northern climates, northern locations, people that work indoors a lot, even in the winter months where it's just cold so you can't get outside, you probably need to supplement with vitamin D. And we talked in the last live, I think it was yesterday, we talked about how much vitamin D. Is it 1,000? Is it 2,000? Is it 5,000? Some people even say 10,000. And that's still up for debate. I know in theory there's ways to overdose or take too much vitamin D, but it would take a lot. Most people are actually vitamin deficient, not have too much. The vitamin K or K2 is a fairly new idea. I mean, it's been around for a while, but this idea of D3 plus K2 has been coming around more. And for those, I haven't really talked about K2, but it is supposedly very good for heart health. And that is always a good thing. But in terms, so you could take a vitamin K2 supplement, and there's some foods that have vitamin K2. But having said that, what I would probably say is take a supplement that has both if you can. Now, again, I've ranted about Amazon for supplements and stuff online, so I'd try to find a quality lab that makes a combination. There is thought that they work synergistically, helping each other sort of act, and so that's certainly a good thing. Not just from a working together standpoint, but there's also thought that maybe they're involved they sort of help uptake of each other. So I don't know all of the details about K2. I'm very familiar with vitamin D because there's so many orthopedic uses or reasons to take vitamin D. But the K2, I agree, is important. And the biggest one, and why I take it as well, is heart health. All right, Osama. Well, PCL full tear. This is really interesting. I was talking about this on a radio show that I do every Wednesday here in Charleston. We were talking about, I think it was Zach Wilson of the New York Jets with a PCL injury. We were talking about which ones need surgery, which ones don't. And Osama, what's interesting about PCLs is that really up until about 5-10 years ago, we used to say, all right, PCLs heal on their own. ACLs almost always need surgery. PCLs almost never need surgery. That is evolving and has evolved over the last 5 or 10 years in that full tears, complete tears, very often need surgery. Now, I know some people will say you can rehab it, do all sorts of quad strengthening, and that will come back. And again, hang on a second. For those of you, sorry, I'm jumping ahead. So if you don't know what the PCL is, all right, so this is my handy dandy knee model. Move the patella, the kneecap, out of the way. You see two ligaments down the center of the knee. The one in the front is the ACL, the anterior cruciate ligament, anterior meaning front. And then behind that, I don't know if you can see it back here, is the big thick PCL, the posterior cruciate ligament. And that's much less often torn than the ACL. I mean, I've seen numbers 20-1 as far as ACL tears to PCL statistically through sports. But having said that, they do happen. Grade 1, grade 2 PCL tears, which you can tell a little bit by physical exam, much better by MRI, usually don't need surgery. There's enough of the ligament there. The body heals the remainder of the PCL pretty well. You get your quad strength back, doesn't need surgery. That's still going to be 2, 4, maybe 6 or 8 weeks. But the full tears, the complete rupture of the ligament, or where you pull one end of it off, and I don't know if I can really show you that on this model, but especially where it pulls off the back of the thigh, back of the femur, back of the thigh bone, that you would reattach maybe with a screw or washer, or if it's a mid-substance complete tear, you would fix it surgically. I know there are people that disagree with that, but the trend has turned over the years to complete tears of the PCL being surgical. I did get a question from somebody ahead of time, and again, I can't go back and read it. It's one of the quirks of Restream. From somebody named Madeline, who was talking about an ACL tear and problems she's having 3 to 5 years later, both with that knee and the ankle below it. And this is a kind of an interesting, I want to bring this up because this applies to a lot of people. The ACL, as I showed you, is the big stabilizing ligament in the center of the knee, provides front to back stability and rotational stability. And it is extremely difficult to play sports on a torn ACL just because your knee's not stable and it gives way. There's no amount of rehab that supplements for that. There's no amount of braces don't do that very well at all. So if you play a sport where you have to change directions or land from a jump and you have a torn ACL, you're probably going to be talking about surgery to fix it. And there's some newer ways, these bridge surgeries where you sort of sew it back together and then you put this scaffold with basically stem cells to try to better heal it without doing a full reconstruction, meaning make a new one. But still the gold standard is the ACL reconstruction. Now, the challenge with that, one thing that we know is that surgery does very well at restoring stability of the knee. It doesn't do all that well at preventing arthritis, which is the question that Madeline had, that she was starting to develop arthritis in her knee. And that happens. Now, it's certainly less likely to happen if you have surgery than if you don't have it, because if your knee just keeps buckling, you're going to get arthritis really quickly, but it certainly can happen. Now, one of the things, and I've talked a little bit on this live show over the last month or two, so I still am an orthopedic surgeon, still double board certified in orthopedic surgery and orthopedic sports medicine, but I'm also doing functional and integrative medicine. So in addition to surgeries and cortisone shots and physical therapy and all the kind of typical things orthopedic surgeons do or recommend, I also do things like peptides and PRP and exosomes and shockwave and hyperbaric oxygen and lots of things to try to get structures to heal naturally. And one of the treatments that I am a big fan of after somebody tears their ACL, whether or not they have surgery, and they're probably going to need surgery, but as soon as that surgery happens, I think it's at least worth considering. I got to be careful because, again, some of these things are controversial, but injections, and you just do them under the skin twice a week, of a substance or a medication called penicillin polysulfate. And what happens is that is very good at sort of minimizing or blocking the degradative enzymes that are just abundant in your knee after a joint injury. So you have the surgery to reconstruct it, but that more or less improves the health. I don't know, I got to be careful the right way you say these, but supports the health of your joint. And I would argue down the road that will be very beneficial. Plus, I know people that do this a lot more than I do even say that people recover from those injuries and surgeries that much faster if they start penicillin soon thereafter. You have to stop any blood thinners you're on, stop any aspirin, but it's something maybe to talk to your doctor about. All right. Nathan, good to see you, Nathan. He says, thoughts on peptides for ATR. I'm not 100% sure. I don't know if that's Achilles tendon. I'm not sure what he's talking about that. But let me answer that question generally. And Nathan, feel free to, in the comments, just tell me what you mean by ATR. The peptides for recovery are an interesting thing. And I'm going to say this on the front end, that I am not telling you that you should definitely have, and he says Achilles tendon rupture. So thanks, Nathan. I figured that's what you meant, but I was just saying that. So before I get into the answer specifically for Nathan, my thing on peptides, I am a big fan of peptides for a lot of reasons. These are short chains of amino acids, up to about 40 amino acids or so. They're made naturally in your body. Your body makes about 7,000, and there's probably more we just haven't identified, in all different parts of your body. They all have very different functions. They're basically cell signaling molecules that cause chemical reactions to happen. Some work in the brain, some work on fat, some work on tendon and ligament healing, things like that. The great thing now is, and we've had this ability 5-10 years now, we can replicate these or synthesize these in the lab to augment your body's response. As you get older, your levels of those peptides drop. So by augmenting that with either a peptide in pill form, or more commonly it's a subcutaneous injection, just right under the skin, you can augment those. And there's a number of those that are very, very good for muscle and tendon healing. I tell you all this because the FDA still I don't even know the right way to call it. Let's just say they still think these are experimental. There are lots of doctors that do them. You can get them from very quality labs. I would not, under any circumstances, buy them online. There's a very good chance that what you think you're buying isn't even in the product, quite honestly. So you need to get, and they have to be prescribed by a physician. That's why I would definitely not get them online. Back to Nathan's question. So Achilles tendon rupture, that's the tendon, well, my ankle model doesn't have an Achilles tendon, so we won't do that. That's the back. Everybody knows what the Achilles tendon is. If it ruptures, very often for athletes, you need surgery. I know there are studies that show some good success rates with non-surgical healing, and in the past, we thought that people that did non-surgical treatment, yes, it does heal, but they have a higher re-rupture rate. That's been questioned in recent years. I will tell you, having worked with pro athletes in many different areas, many different sports, team doctors are going to fix that surgically in a pro athlete. Maybe there's one or two that wouldn't, but I'd be very, very surprised. So where peptides could be helpful would be in helping that tendon repair heal, because Achilles tendon repairs are essentially just sewing it back together. There's all these fancy suture techniques and all, but at the end of the day, it is sewing it back together. Then you wait on your body to heal it. So there's two roles in my mind that where peptides would potentially be helpful. One is to augment that healing, and I would say, peptides like BPC 157 and thymosin beta 4, TB4, would be very effective at doing that. And again, these are very safe. The TB4, some people say you can take it orally. Most people say it works better as a subcutaneous injection. BPC you could take as a pill form, but those I would argue would be very helpful. The other challenge with an Achilles tendon repair or Achilles tendon injury is that getting your calf strength back is ridiculously hard. That's why this is a 9 to 12 month recovery, even for most pro athletes. And so one of the areas, and I know this again is going to be controversial, but if maybe not for a pro athlete, but if this was a triathlete or somebody, my practice, recreational soccer player that wants to get back to play, I'd consider those two, and I'd also consider CJC 1925 and ipamorelin, and those are growth hormone releasing peptides, meaning they cause your pituitary to release growth hormone that's already there. Giving somebody human growth hormone, that's a really bad idea, and we can get into all of that if we have time. But what these peptides do is be like if there was a bunch of people standing on a balcony, the peptide basically is the boot kicking those people off the balcony. It's basically causing your pituitary to release the growth hormone that's already there. And that boosts your IGF, helping you get that muscle strength back. So that would be something that I might consider adding as well. If you were on a sport where you have to get drug tested, though, the TB4 and the CJC and ipamorelin are going to potentially cause you to test positive. So that's something you have to think about. But that is something I would think about for Achilles tendon repairs. See, I get to talk about non-traditional orthopedics. There aren't many orthopedic surgeons that do what I do, incorporating some of the peptides and exosomes and that kind of thing. So I'm really excited to talk about that. If you go to most orthopedic surgeons, they will not have a single idea what peptides are, just for that. Let's see here. All right. Ro, I appreciate the comment on the show. Bad elbow, missing cartilage due to an old fracture, grinding, painful at times. Spurs, do you recommend microfracture surgery? So let me do microfracture surgery in general, and then we'll talk about it specifically with the elbow. So let me grab my knee model again. So microfractures typically done on the knee. I've heard some people get it in the shoulder. I've not really heard it much in the elbow. Microfracture is a surgery that was done years ago, and there's still people that do it occasionally, when you have an area of the cartilage lining of the joint. So the white stuff on the end of the chicken bone, so to speak, that's articular cartilage. And if you have a sort of a hole in it, a pothole in pavement is the analogy I like to use, the idea with the microfracture is that they'd go in surgically and use what looks like a fancy ice pick, for lack of better terms. I don't have a pen around, but basically, and poke holes basically until those holes bleed, and they'd be about every 2-3 millimeters apart, 3 to 5 millimeters apart, I guess, and what that does is that, in theory, that helps grow new cartilage. Now, the problem that microfracture had is that it creates what's called fibrocartilage, which is much more brittle. It breaks down compared to the hyaline cartilage in articular cartilage. So it's not nearly as good. It's much rougher than your natural cartilage. Is it better than nothing? Maybe, but that doesn't see, in real active people, it doesn't really slow arthritis down very well. That's why it's really fallen out of favor, and you're seeing things like stem cells and PRP. You're seeing things like autologous chondrocyte implantation, where they take cartilage, stem cell, or cartilage, generate stem cells, put it under a patch of fibrous tissue, put the stem cells to try to get it to form cartilage. Even taking cylinders of bone and cartilage from another part of your knee or from a donor and putting into that for the knee. Now, I don't know, I do know that you can do microfracture for the elbow. I don't know the success rates. In some ways, it might be better because the elbow is not normally a weight-bearing joint, assuming you're not like a gymnast or carpenter or something like that, where you're having to put a lot of weight on your hands. But microfracture, the other challenge is it seems to work much better for small localized lesions than arthritis throughout the joint. So I don't know honestly how much, Ro, I don't know your situation, so this isn't advice, but if people with arthritis throughout the elbow, throughout the knee, in multiple spots, I would argue microfracture probably isn't going to work that well. Neither will going in and doing a cleanup. That operation has really fallen out of favor in much of the world, still sort of hanging on here in the United States, even though multiple studies show that probably provides very short-term benefit, and potentially even makes people worse in the long run. So not something I'm real big on. Arthritis is a tricky one, especially for the elbow, where elbow replacements are not the easiest or sometimes the best thing to do unless there's no other alternative. That's another one that, something like penicillin polysulfate, or, maybe injections of a peptide AOD 9604 with hyaluronic acid, maybe PRP or exosomes, stem cells. I've got pros and cons about that, but exosomes are along the same lines. Those are all things you could think about. Arthritis of the elbow, short of an elbow replacement, I don't know if there's an easy surgery for that. And again, without knowing more, it's kind of hard to say. All right, Joy, sorry about that, Joy. Reading this from a distance. Tennis player, love that. By the way, Joy, and somebody, you guys, if you watch the show next week, we're going to talk about a study that showed that golfers, if you play golf, it lowers your risk of death by 40%. But apparently, tennis beats that. It's the only sport that beat golf. I'll explain it next week, but it's really interesting. Recent total knee replacement, 3 months out from regaining range of motion, pain, same area of the knee. Sorry, this is kind of long. So. The question about the MRI is tricky, and maybe I've misread this. Total knee replacement takes out the meniscus, takes out the articular cartilage. It basically takes all of this out. So it takes what's left of the ligaments out, takes the meniscus out, takes out the damaged articular cartilage, takes out the damaged bone under that. Same thing on the shin bone side, and same thing on the kneecap side. So there's not really going to be much to see on an MRI. I suppose you could get it, but the other problem with an MRI is that metal is going to just create a ton of artifact on the MRI. That's why they ask you if you have a pacemaker or any kind of device in your body, because it messes up the MRI. So if you got screws in your knee or something like that, it's really hard to get an MRI. It doesn't mean that there can't be sources of pain. There can be scar tissue. There can be a number of different things. You'd have to ask your doctor how much an MRI would help, because what an MRI is not going to show is like loosening of the knee replacement or infection. There's a lot of non-structural reasons for pain after a knee replacement. I will say that getting your range of motion back is tricky after a knee replacement. If you don't get it early, it gets really tricky, and that alone makes it painful, makes trouble just walking normally and all that really, really difficult. So that can be something to think about. All right, Rahul. I'd try to pronounce your last name, but I am going to butcher that, something awful. But thank you for joining us today. Right knee ligament torn. moving side to side when I make a move, strengthening the muscles do any good. And he had ACL surgery for the left leg. Okay, so that's actually one of the interesting things about, and I don't know if, again, without examining you, so I can't really say, but is your knee feeling like it's moving when you go side to side? Is that ACL? It could be. That's, we talked about what the ACL provides is stability from rotation. And that's why it's really hard to play soccer or basketball or something like that without an ACL. But it also could be the MCL, the medial collateral ligament that opens up this way. Some people complain of that same thing. So MCLs typically heal on their own without surgery. There is a small subcategory of MCL injuries that need surgery, but that's pretty rare. Most MCLs healed, brace, time to heal, get your motion strength back, all of that kind of stuff. But ACLs almost always need surgery. If it is an ACL tear, I'm not going to say it couldn't need surgery, but it's very rare. In 15 years of practice or so, I've seen less than 5 ACL, true partial ACL tears where most of the ligament was actually intact and the knee was actually stable. So I feel like for somebody that's saying their knee feels unstable after a specific injury, I probably, if I couldn't figure it out by an MRI examining that, or by examining that person, I'd get an MRI. So that's kind of my thought on that. All right. I think it will come inside, only not outside. I'm not 100% sure what that means. Robert does ask, and Robert, I'm going to have to, since I know you'll hopefully be back next week, I'll have to look this one up. I have heard that as well about the statins, but I don't know. I'll have to look more into the studies. The reason I say that is my concern with saying it causes it is I'd want to see a before and after. And I feel like, especially in men, the testosterone tends to drop 40s, 50s, and on anyway. And testosterone is not a lab we normally order. So when you get cholesterol labs and they put you on a statin, the concern, there wasn't a before testosterone level. So I need to see the studies that they measured people's testosterone before and then after and see what happens, because otherwise that's sort of a correlation, not a causation. So I don't really know. I have heard that, but I'll have to look that up. So I honestly, I just wish I could give you a better answer to that. Mohammed, thank you for joining us, Mohammed. I'm unable to bend my knee after ACL surgery. All right. And he says, tried and he still can't. All right, the trick to that, and he says it's almost a year out. Yikes. That's really tricky. So like I was telling Joy with the knee replacements, if you don't get, and this is not a criticism of you, I don't know the circumstances, Mohammed, but if you don't get motion back after an ACL surgery quickly, it probably isn't going to come back naturally. In my mind, you've got about 4 weeks after surgery to get full extension. Basically, get it all the way straight. After that, it gets really hard. Bending it, getting it all the way this way, you can usually get back, over 6, 8 weeks, maybe 12 weeks, something like that. But you got to get that full extension back really, really fast. That's one of the reasons after I do these surgeries, I've stopped putting most patients in braces. There's a few exceptions, but because I felt like it was limiting their ability to get their full extension back. And so, and I get them into physical therapy within a few days of surgery, and they work really hard on getting full extension back. Once you get to 3 months, 6 months out, and if you don't have full extension, you don't have full flexion, very likely there's developed a lot of what's called arthrofibrosis, scar tissue in the knee, and physical therapy is not typically going to get rid of that. You're typically talking about a surgery to go in and scope the knee and clean out all that scar tissue and try to forcibly get it bending. But even that, most doctors, most surgeons will tell you is not perfect for getting full range of motion back. So again, I don't know the circumstances with yours, Mohammed, but that can be a really, really tricky problem. So either the surgeon that you had or a different surgeon, maybe maybe worth asking, is there a surgery that might make that a little bit better? All right. I did not realize we have already gone 30 minutes, and that's usually what I try to do this show. But I am going to try to do this more often. I promise. These Ask Dr. Geiers are fun. I don't know if it'll be every Friday, but we'll do it as often as we can. Very, very appreciative that you joined us. I hope this was helpful. Again, people ask periodically if they can come see me as a patient. You're certainly welcome to. I can't give advice online, so we may start doing teleconference calls. We were talking about that in my office yesterday, but there's some tricky issues with state licensing and some states' medical boards, so I don't know if we're going to start that. But heck, come to Charleston. It is absolutely beautiful outside. Come to Charlotte, North Carolina, where I'm going to be on Tuesday. I'd love to see you at either of those. You can just go to my website and contact me that way. Tuesday, Thursday next week, again at noon. Tuesday, we're going to be coming not from here, but we're going to be doing the show on the road. I'm going to be in Charlotte, North Carolina, and we will do Better Than Ever live there. I hope you have an amazing, amazing Halloween weekend here in the United States or wherever you are. I hope you have fun. I hope you're safe, and I look forward to seeing you on Tuesday. Take care.